So I'm I too, me too. So I'm sorry to wait for you, and now shall we start the third openEHR summit? I make a little opening remarks from now. Okay. So
Okay.
okay. So this is today's agenda. My session is opening remarks. SARS-CoV-2 is getting a pandemic, and pandemic makes panic and infodemics. Many panic buying makes sold out. For many resources disappeared in supermarket and masks or some required materials. Misuse of disinfectant by some president, and ethanol consumption for disinfect for themselves, but it's not effective and harmful. And UV lamps, 5G networks, demagogues by policy and media. Such infodemics reviewed human beings as still stupid, but rapid reaction by researcher or academician, pharmacist make a very rapid reaction against COVID-19. Theoretical developing vaccines and drug against COVID-19, and civic tech, visualizing site, open source software by civil developer and the government, published open data to visualize such data. So epidemics is a still significant threat even our modern societies, but unknown threat, such an unknown threat makes people panic. Human beings are stupid, and openEHR COVID-19 project is rapidly raised and utilized for COVID-19 prevention, monitoring, such as to treat a COVID-19 patient. So we should stay wise and work hard with openEHR against COVID-19. Is this our mission on this to this openEHR summit, and our mission to the next now and some years for the whole common missions. This is my humble open remarks. Please, Heather, can you share your?
Okay, so let me see if I can share my screen.
Can you share your screen?
Yeah. Try and make sure I share the right one too. Okay, can you see? Are you able to see my screen?
No. Maybe Cindy, you should close your screen first.
Okay.
Oh, it says I'm screen sharing, so that's interesting.
Oh.
Okay.
Okay.
You can see it now?
Yes.
Okay. Good morning, everybody.
Or
good night to those in the middle of the night who are resilient enough to come and join us. I'm really pleased that we've managed to get this going. It's I was getting very disappointed if we had to cancel it or something. So we're a bit late, but this is really exciting. This is a different slide set to what I've really presented ever before, obviously in relation to recent events. But it was actually quite exciting as I was pulling it together, and I had a really boring title, and I decided to call it openEHR versus COVID this morning, Chapter 1, because I think this is the beginning, and it's a story, I think, that's a really compelling story. So I hope that by the end of it I share a little bit of my excitement about what's actually we've achieved as the openEHR community as part of addressing the COVID issue and obviously the effects it's having on our communities. So I put together this timeline a little bit. I mean, this is not my story largely. I've been involved from a clinical modelling point of view, but clearly there are lots and lots of other people. And so I've heard snippets about things that are happening around the world. I've been involved in my little bit, but I know that there are other people doing all sorts of things. So I've tried to pull together what I know, but I'm also aware that this is probably only a small subset of what's happening. But at the same time, it's worth letting everyone else know. And if people know of other events or activities, I'd be really happy to know and kind of add it to this little timeline, if you like. So as I understand it, the work started in February, in the 28th of February, between Ian McNichol and Bjorn Ness. So Ian is based in UK, Bjorn for a company in Norway, and they started having just an informal conversation around what they could do in response to COVID. And they put up a little private chat, I think, from what I understand, on the openEHR discourse site. And they started to draw just a very small group of people involved in that. I wasn't involved at that point. And on March 7th, Ian put up an incubator on CKM, and he started to put up some of the very first drafts of some of the templates related to COPs went live. So you can see from the 28th of February through to the 6th or 8th of March, we've got, what, 10 days, max 9 days even, where they went from initial concept through to an actual implementation. And clearly in between that, they started to develop data sets and the actual software itself. I'm not sure of the actual extent. I think that there are multiple hospitals now in Norway in 2 regions that have implemented this particular application, but it's a pretty amazing effort to go from 0 to a fully implemented system in 10 days. So that was around screening for COVID, so a lot of sort of symptom-related questions, and also confirmed infection reports, I think, were the focus of the 2 templates at the beginning. March 11th, so only a few days later, Bjorn was featured in the Open Health News. There was an article about how the openEHR community was responding to coronavirus. I think that was really, as the rest of us were really just starting to realise it was even happening. And the openEHR Foundation itself, openEHR International, put out a press release. So on the 15th of March, I put up a project in CKM. So there's a difference. The Clinical Knowledge Manager, I'm assuming everyone knows, it's this online tool that we use to collaborate around the clinical modelling. So it's a library of archetypes and some templates. It's a collaborative portal where we get clinicians to review the archetypes that we build, and it's a governance mechanism, basically. So I started to look at what Ian had done with the modelling with Bjorn, and in those days in between, I'd started to kind of think about how we could take some of the very rapidly developed archetypes that Ian had done, which were effectively quick and dirty ones that really weren't designed for long-term use. And I started to look at the data points that he needed and the requirements he had in the templates to see how we could turn those into more generic, long-term, use case agnostic archetypes, if you'd like. So take the COVID specific stuff out of it, but actually add to our pool of archetypes. And so I created a project and started to work on that. And we created on the 30th of March, put up a list around on the discourse site again around the COVID project. In that time, I'd also started to work with Zudong and his team in China around the draft data set for the Chinese guidelines. So these are the official guidelines for diagnosis and treatment of COVID in China. This was a version from early March, the 7th edition, so there'd already been a few beforehand. And we were building a data set based on Ian's initial template, plus the work that I'd done to refine some archetypes. And so that was happening in parallel. On the 21st of April, I became aware of some other work that had happened. It was based again on Ian's initial work in the incubators. And so Impeco, which is a company based in Italy, was building a template for their purposes. And they took Ian's template and they used a couple of the new archetypes that I developed. And they built a template that was based around assessment of COVID symptoms, and it was with a slight nephrology focus. So it was a slightly different tweak, but they reused so much of it, and they did it in Italian. So they were translating all of the archetypes into Italian at the time. The end of May, I became aware of HIMED's work. So this is a German consortium, and they've actually built a whole infection control system. So I haven't seen any of the modelling of that yet, but they've used a whole lot of the common archetypes as well as the basis for that. And in June 10, Zudong's team published in the JMIR a paper around the modelling and how we went about building that, that data set that's being used for the Chinese implementation, and he's going to tell us more about that later. So, you know, I've had a few touch points, but the known community is that we've got about 10 or 15 vendors or organisations who've been involved, and some of them are up there. I mean, Ian seems to have more of a feeling of what's happening in Europe, and so there are, I think, other vendors and organisations I'm not aware of. He certainly says there's been lots and lots of apps that have been tried. There's probably about 10 or 15 that have actually got fully through to implementation that he knows about. And so we've got them in Norway, UK, Germany, China, Italy. I know there have been some archetypes being translated into French all of a sudden, which hasn't happened previously. So there's possibly some work happening in France, possibly some others in Scandinavia as well. And I know Ian's company, Fresh Air, mine, Atomica, and some of the modelers in Helsivest in Norway have been basically supporting a whole lot of this work. So I guess that's a little bit of an overview of the time scale, but as I say, I think that's really probably a fairly limited view, and there's probably a lot more happening that I'd love to hear more about. Some of you have seen this a few slides before, but in the interest of sort of some other story that I want to tell and add to this, I'll go through it again. Some of you may not have seen it at all. When I think about the clinical modelling side of things, which is obviously my world, as the co-lead for the clinical modelling program, I think of it like these Lego blocks in a Lego city, the postage system, all of the other things that make the city work. But the actual buildings and structures, I'd like you to think of those as perhaps the content of our electronic health record, and this is what we control with our modelling and so on. So if we deconstruct that, we can get very easily recognisable things like the crane and the helicopter and buildings and so on. And we can deconstruct those further into individual blocks. And so that very generic set of blocks plus potentially some very specialised ones for different purposes. But underneath that, there's a set of rules, and the rules that set the size of a little round nubbin on the top of a Lego block. If that's out by a small amount, then the blocks don't go together at all. They fall apart, or else you can't get them apart because they're too tightly done and so on. So the rules that underpin all of this is really important. And then within the openEHR approach, that becomes the reference rules. These are the reference model, the rules that hold all of this together. For describing archetypes. So the archetypes being a set of data points around a single discrete clinical concept. So these become our health data patterns that we standardise, that we get the clinicians to agree and publish, and then that we govern within that CKM tool. Think here a diagnosis or a medication order or a blood pressure measurement. These single concepts, there's often multiple data elements, but they group together sensibly at that clinical concept level. And then, whoops, I think I went the wrong way. There we go. Templates are the equivalent of these identifiable objects, the helicopters and so on. These are the equivalent of our documents and forms. These are aggregations of the individual archetypes, so aggregations of the building blocks, in particular constraints and patterns that enable us to represent something that's recognisable. So this is where we manage creating our forms and documents and so on, but also per clinical domain or professional location where we need to actually make it cater for the diversity, if you like. The templates allow that clinical diversity to be expressed, and we govern the archetypes tightly underneath as that foundation. And so what we do is we put those archetypes and potentially templates where we want to share them into this clinical knowledge manager or data dictionary, whichever you want to call it, basically. So this is our CKM resource. So this is what it looks like. This is the URL if you haven't seen it. So it's an online tool, as I said before. You can have access to it. The openEHR community at the moment. Those numbers in the top right-hand corner from about a fortnight ago. So we had over 2,400 users, and we had, I think, from 103 countries at that point in time. So there's quite a large community that we have access to, all volunteer. When we started to then work in this COVID space over the last few months, the modelers have gone to various sources. So Ian used requirements that came from CDC and WHO. He also went online and looked at some of these apps and websites that are coming out of the NHS and the UK government. We've also been using the Chinese guidelines that you can see there, those documents. So we used a whole lot of sources because there really isn't any other existing applications out there at the moment. And so what we did was took those and we analysed them and pulled them apart. And doing that to a Word document is quite a tricky kind of thing if they're not structured in any way. But we pulled them out and we tried to work out what those individual clinical concepts were. So what would be an equivalent building block or an archetype in our world? And so what Ian did when he built those first templates was he took those core archetypes that we had that were well developed and quite mature and robust as a foundation, the ones that are already in CKM, and he built a few others. A lot of them were quite COVID specific because he was working very quickly. As you can see, he only had a couple of days, I would suggest, between when he started building those templates and when he gave them to Bjorn to start to implement. So there's a bit of quick and dirty stuff happening, or you could say it's more agile, and that's realistic. And so this is part of what I think this is a really compelling story. Ian could do that, work really fast. He built a template. So here's a red helicopter, if you like, that would work. And he put them up into that ungoverned incubator. So the incubators are like a play space. We can put the quick and dirty archetypes up there, but we know that they're not going to be part of the ongoing future-proof governed archetypes that are non-COVID specific and so on. But he was able to get them up there and people started to share them, like the Impeco group. They took that and they started with it. So Impeco came along and they took that helicopter and they basically made their own version of it and did it in Italian. So that's where, again, just somebody's effort gets reused and shared. And so I think that was even at a simple level like that, that was pretty cool. It was already obviously translated in Norwegian, so we had it in Norwegian and Italian already. And then with the luxury of time, Sunny and I were able to come along and actually take those initial archetypes that Ian built, and we were able to refine them and bring them into a space that was closer to the governed space. So we built another helicopter, if you like. We built other data sets, and the Chinese data set is more like this. It's got a lot of commonality in it, but we've taken the rough and ready ones that Ian did, and we took the COVIDness out of it, and we created really good quality archetypes that we thought we could take forward generically, and we put those into the governed project. So you can see on CKM, I'll give you links later, you can see the incubator, which is still incredibly valuable because that's what's actually being implemented. But we've also got the governed project, which is actually giving guidance for anyone coming along now of what are more robust sort of future-proof models to take into the future. And I did a mapping between those two helicopters, the two data sets, from the incubator to the project, and in designing those project-related archetypes, I made sure that all of those data points were able to be mapped into governable archetypes. So in fact, there's a few data points, only one or two, that were a little wacky in that they probably had a couple of concepts and they were difficult to tease out. But basically, we've got a one-to-one mapping between that incubator template and the project template, so that if DIPS wanted to transform this into a project project template into the future, we'd actually have them able to migrate that data through. We already know what that migration path will be, and that we know that the data can be captured and recorded appropriately. So it got me thinking around how we develop standards, and the old way of doing it was basically a whole lot of inputs into a bit of a bucket without much of a process, and you swish it around. And I don't mean to be disrespectful, but everyone does it in an ad hoc way. There's not a lot of process. So I'm really trying to emphasize that, I guess. And then you go through a whole lot of iterations, and you do a whole lot of meetings, and you try and decide. And the end outcome is usually a single artifact. So this is something that's a long, complex thing. And what you end up with basically is something that's what is the minimum that everyone can tolerate. So, another way of saying a minimum data set, but it involves a whole lot of difficult discussions that I would say are more often arguments, where it's often people who feel like they've lost. They haven't got the data points they need in, and so on. So there's a sense of people winning or losing in this rather than a collaboration. And this is something that often takes months to years just to get one single artifact. And it got me thinking that the way we do it with openEHR is we do it quite differently. And our secret sauce, if you like, are the archetypes. So these are pre-qualified, right? The ones that Ian started with. There was a whole lot of them that were actually already published or very mature. They've been clinically verified. They were open data standards, and they were a really robust starting point. So we take all the requirements and we bring all of that into CKM, and we've got these archetypes. And the review process happens in CKM. There is a process and a methodology, and it's something that can be central. It's something that can be more distributed. In fact, there are some other CKMs that are also working on it, and we have distributed editors who are able to do this. And so this does take months to years, but we've already been doing this for 10 years, so that the pool that we have in the middle there are some things that have been around for a long time, tried and tested in many implementations. And then when COVID comes along, this is where we start to think, what do we need? So we need a screening assessment, and we need one that's not only in English but in Norwegian, and another one that's in Italian with that nephrology tweak to it that Impeco needed. And then Ian also needed an infection report and the Chinese diagnosis guidelines. But we also have all of these so that they're related to each other. There's actually commonality amongst them. It's not a single artifact. We're actually able to have data that's consistent, and you could potentially be querying across them if you needed to get particular data out. And these templates take days to weeks by comparison, because we've already put the hard yards into building that central pool of archetypes. And they're coherent and data sets, yes. Reminding myself. So this is an old slide I've used a lot, and again it's very similar to the one previously. At this point, it's usually my main message is to say that the archetypes and the templates and the terminology are the key to all of this, and this is where the clinicians lead. So in the openEHR space, the clinicians are building the archetypes, and then we have modelers, usually clinical informaticians, building the templates, and obviously the terminology, but clinicians determine the content. We build these data sets and we can get all sorts of outputs, if you like. But I also wanted to point out that when you've got the archetypes and templates and the terminology together, we can build coherent decision support that is aligned with all of those data sets and with all of those outputs. And we have a guideline definition language that enables us to leverage that. There's also semantic queries that are also based on the archetypes, templates, and terminology. So we have, again, coherent query language. So this is a really good story about how we actually look at the data and look at how we can actually use it into the future for decision support, AI, etc. And instead of focusing on those end single documents like HL7 kind of typical standards process does, we're always focusing on this other side of getting that pool of archetypes and the terminology aligned together really well. This is what I spent most of yesterday doing, and it took much longer than I anticipated, but I think it's actually, I'm really excited by this spreadsheet. So let me try and explain to you what you're seeing here. Here's our incubator column. So we've got Ian's original screening assessment infection report here. and then Impeco's template here. So these are the templates going down in the columns. Here's the project, and here's my equivalent, the project equivalent of Ian's screening assessment and the infection report, and then the Chinese guidelines document. And what we've got down here are all the archetypes. So there's a group down here that are ungoverned. These are the ones that were in the incubator. Here are the new ones that we've built that are actually going to be governed inside the projects. And here are the existing ones that have been around for quite a long period of time. And so what you can see here is that in this particular screening assessment, there were 20 archetypes. In the Chinese guidelines, in fact, we had 69 instances of archetypes, but there are actually 19 unique archetypes. So you can see when you look here, there's a number 15 here. This shows that there were 15 laboratory test result archetypes that were used within that template. So you can see all of those kind of numbers through here. So story was used twice in this particular infection report and so on. So these numbers here in red are saying that 55% of the archetypes in the screening assessment were actually these governed ones. Because Ian built them before these newly governed ones were created, there were 0, in fact, in that the new governed space. And then 45% of his archetypes were from new ones that he built. And now, normally I would say, in fact, most of our experience is that about 75% of archetypes, when we build a new template, we already have. It's slightly lower in this case because there was a whole lot of questionnaires and things that we haven't really dealt with in the past. So it brought up a whole lot of unique content that we haven't come across before. When you look at over here in the project, you can see that the screening assessment used 81%. And the Chinese guidelines, in fact, used 91% here, and 9% of these new ones, and basically there were none in this ungoverned space. Obviously, this is where I built one that was using one of these ungoverned ones, which I'm not quite sure how that happened. So that's probably an aberration, but that's what it is. So what you're actually seeing here is that's where the red helicopter is, the purple helicopter, and there's the equivalent. So this is, if you're trying to kind of conceptually relate back to some of those previous slides, this is the projects versus the incubator templates. The Gartner has created this kind of notion and written up around openEHR, and they talk around systems, in fact, being ninja and samurai, in that some of the old established megalith systems are the samurais, and openEHR comes in to be the ninjas. But Ian McNichol from UK likes to talk about this in the way of modelling as well. So he saw what he did as far as building these ungoverned new archetypes that were COVID specific as doing the agile ninja stuff. He likes to describe me as doing the samurai stuff, if you like that kind of analogy, I'm not sure. But you can see here, when he built these new archetypes in this incubator, most of his, a lot of his work was here. In fact, when we built them and we put them into templates, a lot of that ninja stuff has not been used. And in fact, we're talking about the governed future-proof stuff. So I think seeing that these numbers are so high, and in fact, for the Chinese work, really 100% have come from these newly governed ones, you get a sense of how this is evolving, I guess, in a strategic way. And when we actually move those archetypes from these ones and we created these ones to replace them that were non-COVID specific, we've effectively moved them up into this space. And so there is a strategy and there is a methodology that sits behind this that I think allows the ninja stuff to happen really rapidly, but we also have a process by which we can create good quality archetypes into the future and ensure that we actually have the mappings between them. So this is a methodology that allows us to be very quick and agile, but also have a governance process sitting behind it. And that's quite unique. I find that actually really exciting to see that. The other thing I wanted to point out that in CKM, we've got archetypes in 27 languages. Now, some of them only have 1 or 2, but in this Italian work, they did some translations, and we've now got 34 Italian archetypes. This is the problem diagnosis mind map. Here we've got the same one in Norwegian, and there are 227 archetypes that have been translated into Norwegian. And here we've got 15 now in Chinese. So that's the problem diagnosis archetype as well. But I'll also point out that I think Zudong will hopefully speak to that the HMC is a website, effectively our Chinese equivalent of the CKM, which currently has 441 archetypes, clearly in Chinese and English. So the highlights for me, and this is effectively the last slide, is we don't have any COVID-specific archetypes in the projects. They're only in the incubators. So we've got really good archetypes that cover all of the COVID-specific stuff now, without it being COVID-specific, if you like. So it's enhanced our pool of archetypes, ready for whatever we need to use in the next time. It's tested our published archetypes and refined any draft ones that we had. So it's been very good from that point of view. We've identified a number of new modelling patterns, particularly the screening questionnaires that we've now got as a group. There's about 5 or 6 of them for different topics, but we avoided questionnaires previously because often they were so ad hoc and random depending on what people wanted to have in a questionnaire. But screening ones, like if you're screening for symptoms, it's typical for what clinicians do when they see a new patient and they say, do you have any fits, faints, dizziness, numbness, weakness, headaches? We'll have a symptom screening questionnaire that will be able to support recording that kind of thing. We also, I've had a number of conversations over the years about how to record a travel history. So we've been laser focused in actually being able to record that kind of thing now. And we've got the notion of a therapeutic order, which is very akin to a medication order or similar, but it's for things other than medications. So it might be administration of oxygen or administration of a bandage or something like that, therapeutic stockings. So it's adding a slightly different dimension. So this has been really welcome new admissions to the archetype pool. It's been lovely to see the international community to collaborate. And as I say, we still really don't know the extent of that because CKM is an anchor, if you like, but we don't make people tell us what they're doing. So there could be all sorts of people using the openEHR models and using them in their own particular situations, but we don't know about it. So we get, all of these were independent implementations. They were multilingual. And where you can manage that incubator versus project tension with our methodology that we've got. So the thing that I think is really the gold star for me is that we've got this process that takes us from this agile COVID specific work through to that stable generic stuff with about a 98% mapping. That to me was, and I've been doing this for a long time now, for over 10 years, but to actually see that evolve for real was one of the most exciting moments that I've had in this work that I've done to date. This is pretty special stuff that you can't do with other standards. And it's how do we get that story out and how do we actually even describe it so that others start to understand what the benefits are of this. So this is the story I know, and I think there's more to be revealed, and I'm hoping to learn more in the rest of the day. I've put together some resources here that I can share the slides and share those links. So these are all links to sort of the articles and some of the discourse sites and so on in the original timeline so that you can look at those in your leisure. And I think I'll leave it there. Thank you, Shinji.
Thank you, Heather. So there is a question about governed and ungoverned from Bunchai. Could you explain what we mean by governed and ungoverned?
So in the CKM space, there are basically there's the ungoverned are the incubators. So this is basically a space that we can give people. It's like a folder, I guess, in CKM where people can put archetypes and templates up. And they can effectively take very raw ones, very new ones, and start to collaborate within the CKM space. But they can do whatever they like, and there's no governance from the editors or the administrators of the site, and they can let things evolve fairly fluidly. Think of it like a a sandpit or a playground or something where fairly immature things are just kind of becoming formed. But when they get to a mature point and we want to bring them into the governed space because the archetypes fit with the patterns that exist in CKM, or there's value there that we haven't got otherwise, then the editors make a choice to be able to promote those archetypes into a project. And so all of the projects are governed, which means they're governed from a content point of view, so that the archetypes become draft or in review or published, and they can go through a review process. And then we also manage, once they're published, we manage the versioning from a technical point of view. So suddenly there's a whole lot of levels of governance for publication as well as for the technical artifacts and the versioning and so on, so that implementations can track what's happening with the archetypes as well. But we try and stay away from that when things are fairly new and fairly fluid. So that was really what Ian was doing in the early days. And then we've brought that into that governed project space, which is where most of the robust authoritative archetypes sit. Does that help?
Okay, thank you, Heather. So next, Professor Lu, please.
Okay. Before Dr. Meng Yang and Shan started their presentation, I will explain a little bit. Maybe I will take 1 minute to explain our project. So so we have the openEHR based CDR. It's named Clever, have been implemented in one hospital in Wuhan, China. So you know, Wuhan is the first city to have suffered the COVID-19 epidemic, and the hospital. The name of the hospital is the Central Theater General Hospital of Army, the PLA. So it has accepted around 700 patients got severe. Those patients are severe cases. So we cooperated with them because they already have this openEHR CDR. So we cooperated with them to initiate the project to start the decision support tool for COVID-19. So the next presentations will explain how we model the data by openEHR. It's also we got support by Heather, and is very thankful for her help to our project. And also the modeling work will be presented by Dr. Meng Yang, and also Dr. Shan. Shan will explain the guideline-based decision support tools. So please, Dr. Meng Yang, can you share your screen and start your presentation on the modeling?
Hello, everyone. I'm Li Mengyang. I'm a PhD candidate from Zhejiang University. I have been working in medical informatics for about 4 years in the group of Xudong. At first, I mainly focus on the technical implementation of openEHR. That is how to develop various information systems based on the archetypes and templates. In this process, I am also working how to develop openEHR information models. Therefore, I hope my report can bring you some understanding and thinking about openEHR. I would be honored if it could be helpful. And I'm going to share how to develop openEHR templates for COVID-19 on clinical guidelines. First, I will give our motivation for the research. Then I will talk about the method we used and give some discussion and the limitations of our approach. After that, there will be conclusions finally. The background of our research is the large-scale spread of the COVID-19. Although when we started our research, the epidemic mainly occurred in mainland China, but it has now broken out around the world. Thus, poses a very challenging threat. According to the data from Johns Hopkins University, more than 15 million people around the world have been infected with the disease. At the beginning of the outbreak in China, there was some confusion due to a lack of understanding about the disease. The National Health Commission of China quickly issued the clinical guidelines to deal with the situation rapidly after realizing the severity. So, how to apply the guideline in clinical practice is a challenging issue. It involved what information clinicians to focus on and the identification of mild and severe cases and how to deal with these different cases. The computer-aided clinical decision support tool is an effective way to solve these problems. At the same time, in such a situation, which is short of medical resources, it can greatly improve the work efficiency. In CDSS, such as screening, the interaction with other systems is inevitable, and a problem involved in this interaction among these systems is the interoperability of the disease-related data. Therefore, we need an information model that supports the interoperability. So, to be detailed, our needs is mainly in two aspects. The first one is to develop the model quickly, because such a large-scale epidemic brings good pressure and panic to individuals and society. So there is a great demand for medical resources. The rapid development of the model is of great significance, not only to individuals, but also to the society. Second, people have no idea about COVID-19 before, so people's understanding about it is constantly changing and improving. That is, knowledge will be revised and updated continually. Therefore, the rapidly changing knowledge requires that the modeling method can deal with it. And we found openEHR can meet our demands very well. First of all, it has an open platform, that is a CKM, where everyone can share their knowledge on it for reference and used by others. And the state of the architect can tell you which is mature and can be used in production environment, and which needs to be improved, that is not recommended to use them directly. And it helps us to quickly find knowledge that meets our needs and apply them directly to our problems. Secondly, it separates the technical implementation from the knowledge management. That is, it can be divided into reference model and archetype model. Because the knowledge is constantly changing, the archetype model is can be constantly changing with it, but the reference model is relatively stable. So the technical implementation basically don't need to be modified. So it can adapt to the situation of ever-changing knowledge, like the situation of COVID-19. So we use openEHR method to build our information models. We hope to use the archetypes available in CKM and knowledge extract from the guideline to build our template. The process is divided into 7 steps. First, informaticists extract data items from the clinical guideline, which requires the participation of the medical professionals. For the extract data items, there exists semantic overlap and inaccurate classification in these data items. They need to be further organized into domain concepts, which is mainly complete by informaticists, but also requires medication professionals to have a review. In this process, domain concepts is present within a mind map to make them easier to organize. After that, we will go to the CKM to query archetypes that correspond to these domain concepts. And if not all domain concepts can be found, we need to develop them from scratch. And finally, use these archetypes to build our template. When develop the template, we need to discuss with medical professionals continuously. The final template can be used in some practical applications, including CDSS and data reporting. So the following are our detailed steps. The trust knowledge resources are very limited at that time. The epidemic didn't spread on a large scale around the world, lead to there no direct understanding of the disease. After the first wave of the epidemic, China had a great deal of knowledge and information since then, and issued clinical guidelines to deal with COVID-19. So we use the guideline issued by the National Health Commission of China as the source of knowledge. The guideline is divided in 13 parts, 8 of which are selected as direct sources of knowledge. For other content, like sections 1 to 3, just describe the general knowledge of COVID-19, most of which will not directly used for the judgment of diagnosis, treatment, or management. Sections 12 and 13 illustrate the regulations and policies for transportation and infection prevention, and will also not be used for data sharing for the diagnosis and treatment. Although the guideline is written in free text, there's also a hierarchical structure in it. We divide the guideline into single sentences, and the manual instruction is carried out by 2 people independently. After instruction, we review each other's results and keep the same instruction results. For different results, it is necessary to medical professionals to review the differences and resolve the conflicts of different instruction results. And in this process, 2 principles should be observed. The first is to maintain the structure of the guideline, because the organization of the content is also a kind of knowledge, which lays the foundation for us to organize domain concepts later. The second is issue that the instruction work is carried out independently. In this way, we can reduce some errors from manual instruction. The final result is present in Excel. The columns correspond to sections, subsections, and data items extracted from them. The data items based on the previous steps needs to be further organized into domain concepts. First of all, for some data items with the same semantics will be merged into the same item, such as coagulopathy and the blood coagulation disorder is uniformly represented by the blood coagulation disorder, which is aligned with the item from the cinema CT. Second, the extract data items needs to be reclassified into the same domain concept, such as fever and difficulties in breathing can come from different sections in the guideline, but they are all regarded as the simple terms. Third, some required information may not be mentioned in the guideline, such as operations, but is also needed in the clinical practice, and they should be considered in modeling. Finally, we organize the domain concept into a mind map, which is easily to use and understand to discuss with medical professionals for continuous improvement. According to the organized domain concept, we go to the CKM to query available archetypes, and we hope to make the best use of the existing archetypes to complete our work, which is our requirement, and it is also an important support that openEHR can provide. Of course, when there is no archetype available, we need to develop it from scratch. But this kind of work undoubtedly brings good hindrance to the research process. But our research results show that all the archetypes are available in CKM. So based on these archetypes, we use Ocean Template Designer to build our template. In the process of the template development, we have great support from Heather. We have many online conferences through Skype. It gives us a lot of suggestions from the clinical practice and terminology use and so on. And we work together through online archetype designer to constantly improve the template. The process of review is essential in the development. In effect, there exists a review in every step because the problems existing in the previous step will directly affect the results of the next step. In the end, our group conducted a detailed review, not only from the perspective of the organization of the domain concepts, but also from the informatics, like the data type of each items and so on. After that, the template was released to CKM for review and reference, and we also hope to make a contribution to the openEHR community and share the knowledge and the experience found in China to other countries. So in our final results, 203 data items are extracted from the guideline, which are classified and organized into 16 domain concepts, corresponding to the domain concepts. All archetypes can be found in CKM, so there's no need to develop archetype from scratch. The template developed through the cooperation of informaticists and domain experts can effectively promote the interoperability among different systems. The template can be applied to the construction of clinical data repository based on the CDR, such as CDS for screening can query data directly from the CDR and return the inferred diagnosis and other treatment to the CDR by inference engine. The role of the templates in semantic interoperability greatly improves the efficiency of interaction among these systems. When we start our research, the knowledge we obtained was not that rich. However, due to the continuous updates of knowledge about COVID-19, in a short period, less than 3 months, the guideline has released 7 editions. A large amount of knowledge have been added. So for the new knowledge, we update the template according to the existing developer process, as I mentioned before. For changing the knowledge, we need to update the template after comparing the difference. For the delete knowledge, template needs to be constrained to make the old knowledge not appear in the final applications. In our research, we found that openEHR two-level modeling approach can indeed help us build a flexible template to deal with the current situation. However, a prominent problem is that implementation and adoption of this method is relatively light, especially in China. It is easy to build various applications on CDR based on openEHR due to the use of an uniform that conforms to a unified specification. The efficiency of the interoperability can be greatly improved. For example, we have built openEHR-based CDR in a hospital in China, which has received more than 700 cases of COVID-19. They are all severe cases. So based on our research, screening tools for COVID-19 are designed use the same template, so it can query the relevant data seamlessly from the CDR and read back screening or diagnosis results to CDR. However, for databases that are not based on openEHR, the advantages brought by openEHR cannot be brought into full play. To make the best use of the advantages of openEHR, IT manufacturers need to cooperate with medical institutions to put forward satisfactory solutions to solve various problems encountered in the medical field. Although our research has been welcomed by medical institutions, it is helpful to deal with the serious situation brought by COVID-19. But there's still some problems. First, the only knowledge source we use is clinical guidelines issued by the National Health Commission of China. But with the continuous spread of the COVID-19, WHO and many other countries have issued relevant guidelines or suggestions, which also contain a lot of knowledge and can be used as an important source of knowledge. Due to the mechanism provided by openEHR, the addition of this knowledge will not affect the operation of the applications built on previous guideline. Second, we always regard the discussion with the medical professionals as an important part of the research. Due to the limitations of the abstract conditions, we can't get enough real opinions of front guideline professionals. These people have been under great work pressure, so it is difficult for them to allocate enough time and energy to participate in our evaluation work. In review of the current epidemic of China have been brought under control, we are gradually improve this part of work. In general, our research proves that openEHR, the open and flexible modeling method, can meet the requirements such as COVID-19, where the people is updated rapidly, and the developed template represents the knowledge in the guideline and shares it on CKM, which can help cope with the spread of COVID-19 epidemic. The development method used in our research can also provide reference for other information modeling work. So that's all. Thank you.
Thank you. Thank you, Mr. Lee. There is a question from Dr. Bunchai. Is this COVID-19 openEHR system implemented in real world?
Okay, let me answer this question. So actually, the modeling, the template has been used for the clinical decision support tools, which will be presented by Dr. Shan in next slides. And the system have been tested and trial usage in the hospital now. You know, because now in China, although the patient, the COVID-19 patient is very few, but the hospital still needed to screen to screen lots of patients in outpatient department and to make sure no new patients will be happen. So it has been tested in the hospital now. Maybe in the next slides, the next presentation, Dr. Shan will explain in more detail.
Okay, please. Please.
Dr. Shan, please share your
Dr.
screen.
Shan, right?
Yes.
Uh,
So I hope you can see my screen right now.
Yes.
yes, please. Yes.
Okay, so morning everyone. It's a great pleasure to share our work in this summit. I'm Shannan from Zhejiang University. So here is a very brief introduction to me and my group here. So I'm a postdoc researcher right now in Zhejiang University, and I'm experienced on clinical guidelines and also rule-based clinical decision support systems. So this is our team that we have a very big team here. And our group is the earliest medical informatics research group in China. So it's kind of very experienced in information systems, decision support, and also those kind of data modeling, and also other kind of support, decision support. So for this specific case, the COVID-19, we have called up army to fight with this disease. So we have two leaders, both of them are openEHR ambassadors. And we also organized a team, a core team that work with modeling and also work with decision support. So these are the pictures that who has participated in this work. So we have Mr. Yijie Wang, who has taken part in managing this process and did a lot of supportive work in this process. We have Mr. Kuai Yu, who is the software engineer, who has helped us a lot in developing the clinical decision support systems and also some development work. And we have three students here worked a lot for this project. We have Meng Yang, who has just gave you a presentation. And we have another two students who has worked on the rule authoring and also the data modeling. So in the next slides, let me give you some motivations that why we carry out this work. So this is a screenshot that I made from Johns Hopkins yesterday. So there are 15 millions of people affected with COVID-19 virus in the past months. And there were more than 600,000 of them already passed away because of this disease. And I make new screenshot this morning, and you can see the number has increased significantly. There are 200,000 people affected this virus just in yesterday, and there are, let me check, there are almost 10,000 of them just died yesterday. So it's quite a big number. It is obligatory for everyone to fight with this disease, especially for our informatics, medical informatics. We are quite obligatory to take actions. Indeed, people are taking actions from our communities. That we can see this early work. openEHR communities has taken action in the early March, as mentioned by Heiser just now. We have developed some apps and archetypes for screening, and also the other communities in the informatics, such as this work has been reported in GMIR, a lot of imaging processing, smart diagnosis, and ways to mirror the social effect of this disease have been carried out and published. Yet, we found something interesting here. So here is an article who did some social study to ask for the attitudes and perceptions of COVID-19 during this crisis. And the result is quite astonishing that quite a lot of people, or let's say most of people, have not aware of the disease, and the treatment and diagnosis criteria are quite unclear to them, not only in undeveloped countries in Africa, but also in developed countries like Europe and America. So we can draw a conclusion here. There is quite a lack of evidence-based clinical decision support systems and knowledge base. This kind of work has not yet been reported currently. This is kind of surprising to us because since the very early stage, the Chinese are working on publishing guidelines. So the first case of COVID-19 has been reported in December last year, and just after less than 1 month, the first edition of the Chinese guideline has been published. And then in these 2 months, we have updated the guideline to the 7th version, which is quite stable right now. So also this kind of guidelines has been translated in English in the early March. And actually that part of work are taken by us as our English resources. However, this kind of work are not widely accepted. Some people are working on sharing the knowledge over the internet. Alibaba has investigated a lot of money on this work. So a lot of books has to be written, published, and released on internet for free. There is a website for that. However, it is still not quite accepted worldwide. This is quite unfortunate, but somehow as informatics, we can understand the reason behind it because there are different languages, although those kind of guidelines are translated in English, but still not every country are speak English. And also the narrative guidelines needs proper interpretation. So different people has different interpretations to the guidelines. So it's hard to understand somehow, especially considering the different background, different medical cultures, different countries. And another different thing is it is quite to integrate these guidelines to heterogeneous information systems, to different medical cultures, to different medical institutions. So there is kind of need for Rosetta Stone to, to bridge people, to help understanding between each other. And we believe openEHR is quite to this direction. Like we mentioned before, it's a global crisis. So global crisis needs global collaboration. openEHR has inherent global collaboration behind it. So there are quite a lot of people using this standard, sharing this among the world. A lot of the knowledge in CKM can be reused and already being created and shared. And besides the advantages mentioned by Meng Yang, which was the openEHR archetypes can make the information model easy to share, easy to understand, easy to reuse. There is another advantage of openEHR that it has a guideline definition language to formal guideline to a computer understandable way, that this language can take the advantage of the openEHR archetypes to facilitate reuse of these archetypes and make it easy to integrate with information systems, those heterogeneous information systems. So with this approach, the guidelines can be easily shared in different languages, in different countries, in different systems. So this motivates us to consider our mission. So the first thing is, although there are approaches, there are tools to support, create guidelines through narrative guidelines and uses tools. However, the approach of doing the things are quite unclear to us or to anyone right now because there is not a specification for that. There are tools existing, but there is no very clear guide for us to do it. So the first thing is we need to specify guideline acquisition approach using openEHR. And the second thing is after having this approach, we need to develop and disseminate a guideline using this approach for COVID-19 in a very rapid way to help the people. And third thing is after we having this guidelines available, it is our duty to implement CDS applications to fight with disease in real clinical sites. So let's start our first part. This is the COVID-19 computer interpretable guideline, R&D. So based on the previous work, we have proposed the rapid guideline acquisition approach here. So the others has already proposed some guideline definition or guideline authoring approach, which is normally needs medical specialists and informatics work closely, face-to-face, have very intensive discussions to decide which part of guideline needs to be authored, needs to be lived out, and also which kind of information model or data model should be used in this guideline. And then they use guideline authoring tool to edit a computerized guideline. And then they validate with clinical cases and then use in their own department, their own institute. However, this case is not really applicable in the COVID-19 crisis, as we are locked down in our own home at that time, and it's very difficult to have medical resources because they are working with their own business to save the people who has disease. So we couldn't have too much discussion with those medical informatics, those medical specialists. So in this case, the openEHR approach is quite helping to us because by reducing the archetypes, we can already have those medical knowledge that are clarified by previous work. However, the work still needs to be some clarification, especially considering the output artifacts of each step, because the outputs of each step is not clarified in the past. It is quite unclear for participants to understand which is the input and output of each step. This is particularly important in this case because we work in different places. We can only share the files through the internet, so the understanding cost is quite high. This is the motivation for us to specify this approach. So by combining the other approaches, what advantage? We propose an approach like this. We call it a rapid strategy development process. So the first step is create guideline knowledge specification. That is by a medical specialist and informatics like ourselves, we decide which part of guideline should be selected and segmented and made into information models and clinical rules. And then the specification is written and shared among within ourselves. And then we start to extract guideline knowledge. So informatics are mainly responsible for this because medical specialists are quite busy at this time. However, this kind of extract knowledge are reviewed by medical specialists. And the output of this step is we have extracted guidelines, which is marked in the right-hand side. So this extract guidelines have two parts. The first part is a relation table, which marks the logical relationship in each part of the guideline in the SAR format, which means situation action rule format. And then the details of the rule are extracted into entity table, which marks out the terms and also the data structure of this guideline. And then these two parts are clarified and specified in openEHR based approach. The entities, or let's say the data elements, are modeled in openEHR, and appropriate openEHR archetypes are selected, and these concepts are modeled in openEHR templates. Another part is the rules. The rules are then used GDL editors to create it into GDL rules. And then these two things are combined to make application prototypes. So that is the validated computerized guidelines. So we use the inherent functionalities of GDL editors to validate the rules with real clinical cases. And also clinical applications are developed to further validate the effectiveness and also the usability of these rules. And finally, these rules are released and disseminated to communities like the openEHR communities, and also we have shared these things in GitHub. So let's see some details. The first thing is we need some tool to support our own approach. So this, our colleagues, Mr. Izie Wang, proposed to use Confluence to support the process. So Confluence is a collaboration platform that enables people to share their documents, their thoughts on this website. So the previously mentioned 6 steps are specified in this website, and the archetypes are pasted and reviewed in this website. So the whole process is manageable and transparent to every participant in this process. And then let's see the details of each steps. The first step is to extract the relations in this guideline. So we copy the PDF files to an Excel file. So you can see the column here, original guideline text. We segmented meaningful paragraphs from the PDF files and then mark them based on their logical relationships. So the guidelines are, the sentences are broken into 2 parts. The if part, which describes the conditions, and the then part, which describes the actions or the decisions need to be made. Then we translate Chinese into English with reference to the translated English version guidelines by the others. This is how we segment guidelines. So as Mengyang mentioned before, not all the guidelines are segmented and extracted. We only care about diagnostic criteria, the clinical classification, clinical warning signs, differential diagnosis, treatment, and discharge sections of the guidelines. So only these parts are copied from the PDF files and translated and segmented here. So the second step is to detailize the entities that are displayed in the previous page. So we look into each sentences to find the unique data items in each sentence and elicited them in another Excel file. So you can see the first column, data item in the guideline. So we find out the guideline items and mark them out in this Excel file. And if they are similar, we combine them. This work is finally reviewed by medical specialists to make sure that these data elements are meaningful and can be extracted and can be translated to openEHR data model. So then the data model is elicited and related archetypes are funded and adapted. This work has been introduced by Mengyang just now. I will not go to too much detail here. What's worth mentioning here is this approach and this work has been made into a publication in JMR here. Here is a link. If you're interested, you can check it. So another step after the data model is ready is to author the rules in GDL2 editor. So the GDL has combined these four main parts. The top level is the guideline meta model itself, and then it is terminology that needs to be used together with this data model. However, the terminology has already been considered in the previous step, so the terminology is not our concern here. What we concern is guideline definition itself. So it has the data binding, which is the rules data element, the relationship of the rules data element to the archetypes data element, and also the root itself, which means the situation part, which is the when part here, and also the action part, which is then part here, and also the guideline is to output somehow. The output is also written in openEHR archetypes. Here it goes to the details of how we create guideline. So this is the basic layout of the GDL2 editor, which is open available on the internet. This is the first step of create guideline. That is to fill in the meta information, which describes the purpose of this guideline, and also which kind of references are being used, who are the authors. Here you can see this guideline is authored by Hong Shuofeng, which is our master student here. Once the guideline is created, the first thing is to import the archetypes. So these archetypes are created in the previous step by Mengyang's subgroup. And there are totally 27 archetypes used here. And these archetypes are imported from the openEHR, the GDL2 editor. Then, after the archetypes are imported, it is important to bind the data to the data items which should be used in the rules. So the data binding can be divided into two parts. One part is the input data, the other is output data. Input data is the data that acquired from the electronic medical record systems or the other clinical information systems. The output is the actual output of this guideline. We also use the openEHR archetypes for the output purpose. Here is some detailed process on it. First, we click the archetype instantiation button, and then you can see this part. And then we define each data binding relationships and use it as input. And then we go one step further to select one archetype and elicit the items, the elements in it. For instance, here we choose the body temperature archetype and choose the temperature here to define the binding relationship between the archetype elements and the data items that should be used in the rules. And then after all the data has been banded, we can then create the rules. So the rules also has two parts, which is the conditions and the actions. In the conditions, we use the data items that we banded in the previous step. So here is the input rule, which is imaging funding has ground glass opticities. So this is, so you can see example here. This is a rule, sorry. This is the rule from the guideline that if CT image report contains certain terms, certain symptoms, then the patient has a higher risk factor. So this page shows the rules, how it expressed in the GDL editor. So the rules are really formatted in the all format, means all of these rules can, all of these conditions. If one of these conditions appears, the rules should be fired. In the right-hand side, you can see there is a list of the rules, which shows all the rules that should be implemented here. So if we want to add a new rule here, we click the link here, add new rule. So totally there are 18 rules authored in our work. So this is the logic output of this rule site. It also reflects the logical structure of the guideline itself. So this guideline is used for COVID-19 diagnosis and treatment. The first step is suspected cases diagnosis to screen the suspected cases. There are 3 rules for it, which is to count the Y cell, which is to count the lymphocyte cell, which is to make the general suspected diagnosis from all these perspectives. And once the suspect cases are made, if the patient is suspected, we will go for a more detailed diagnosis, including the differential diagnosis. So there are some antibody detection, 2 rules are used for it, and there is the general confirmed diagnosis rule for it. And then if this patient is confirmed with this, there will be some general treatment rules to give suggestions to the caregivers, which kind of general treatment should be given. And then there is a critical case classification to detect if this patient is critical case or is mild or is just moderate. There are 2 rules for classified. One rule is just for classification. The other is clinical warning sign, which is used to predict if the patient will be critical or even lethal later. So if the patient is critical, he or she should be given supportive treatment, including these rules: respiration support, circulation support, and also some plasma replacement, body purification, and also continuous CRRT and other supportive treatment should be given here. And after the diagnosis has been made and the treatment has been given, after a few days, the doctor should decide whether the patient meets the discharge criteria. So there are 3 rules for elicited the discharge criteria. The first is out of hospital rule, which is to screening if the patient is eligible for discharge. And then there are 2 tests or 2 decisions should be made. One is body temperature is stable and under 37 degrees centigrade. And also the nuclear acid test is negative. So once these 3 criteria are met, the patient can be discharged. Otherwise, general treatment and other decisions are still used. So this is the basic layout of our rules. And then the rule is validated and tested in the GDL2 editor. So there is a dedicated execution test function in GDL2 editor, which is designed to test the correctness of the rules that we authored in this editor to make sure that our rules, the result of our rules are as expected. So we use the real clinical data, which is adapted from the published patient case report, which is actually the first case of the United States, because that's the only available data source at that time. We use the data source and input them in the input panel on the left-hand side. And then if we click execute, we can say from this editor tool, which rules has been fired and what is the execution result. So this is our work of the creation and disseminate of the guidelines. So after we finish that work, the guidelines has been shared in both GitHub and openEHR. So there are two QR codes. You can scan it if you're interested. They lead you to the website we have published our rules. And also the whole work that I introduced previously has been made into a publication, which also submitted to JMIR. The first round review has been finished and some comments have been sent back. And we are currently working on a response to that comments, and new revision will be made soon. So after the clinical rules are made, it is our duty to implement CDSS. So there are some clinical requirements even now. So although the disease has kind of under control in China, but small scale breakouts still reported in a lot of areas in China. So in April, it's Jilin and then Guangdong province. Then in Beijing, just a few weeks ago. And in this week, Xinjiang has reported some new cases. So this kind of disease screening and disease control, we expect would still exist for a long time. So we believe, and not only we believe, we talked with the doctors in hospitals. There are two possible scenarios that the clinical rules can make their value. The first is the COVID-19 diagnosis at the fever, respiratory, or infection clinics. So that is in the outpatient department. The doctor still needs to screen which patients are in risk and to find out, to decide whether they are suspected for COVID-19. And the second scenario is that to screen suspected cases in the whole hospital, that in the in-hospital department, they can have in-hospital infections, and also they could be dangerous to other patients. So this is like the background application which is running to detect who is suspected in this hospital. So these are the two scenarios that GDL rules can be applied. Previously, we have proposed a framework to implement the rules very quickly. So we can integrate with different rule-based CDSS or as the rule engines, and to define the UIs with our own editors. And then the applications can be made without much coding. So it's just by configuring different rules and different UI components. So we wish to use this framework this time to directly use GDL rules and GDL's execution engines and design the UI directly by this tool. However, this is our ideal thought does not completely work here. The UI can be designed here. However, what we find is there is currently lack of open source or free GDL execution engine at this time. GDL can be executed in its editor. However, we cannot execute a GDL rule out of its editor. The execution engine is currently a commercial engine that we cannot use it for free. However, we thought there is a way to solve it. This is an example of a GDL rule, and this is a truth rule. The truth is very common format that can be used in rule-based systems. We made a very simple comparison. These two kinds of rules are very comparable. So both of them are in when-then format, which are the situation action rule. And in each part, which is all of them are some judgment, and they can be some very direct mapping can be made between them. There are 3 items for data comparison and 1 item for decision making or conclusion. So there are 2 works need to be done here. First is the openEHR archetypes need to be translated into object data model, which was in Java. And also the GDL rules expression needs to be translated into the expression language that Juice can use, which is the Mobile language. And this is the mapping work actually carried out. So the category is as mentioned by Mengyang just now. The openEHR archetypes are fallen this 8 categories, and each category is translated into an object data model in Java format, so that this object data model can be mapped with the actual hospital EMR interfaces. And then we map the rules accordingly. So all of these guideline sections are then made into juice rules. However, I want to clarify here, we didn't map the rule in a 1-by-1 form because there is currently some limitations of GDL. Let's see, for section 5, 10, and 11, there are multiple GDL rules for 1 section. We didn't intend to do that. This is because GDL to editors now only allows 1 rule in a file. However, these sections are kind of complex, so a lot more than 1 rules need to be applied for 1 section. This is why we separate them in GDL rules. However, in juice rules, with the purpose to increase its clearance, we combine these rules together as 1, so that is easier to be understood by the software engineers. And then we made some deployment and clinical trial plan. There are already 2 CDS applications that we have been developed. The first one is also shared on the internet. The demonstrations have been shared. You can scan the QR code to visit our application. This is for the out-clinic diagnosis treatment. So the data can be integrated from the hospital EMR. So from them, the test and also the image can be acquired, and then decisions are made to support the outpatient doctors to find if the patient is suspected or this patient has certain treatment or further examination suggestions are here. Another is a screening in the hospital level, that in the background, the management department can check how many fever patients are in each department and how many are suspected, how many are confirmed with COVID-19. So these applications have been developed and now they are being deployed in the hospital that Xudong just mentioned. It is currently in the deployment phase, which means it's still not yet online yet. We planned the observational before-after study to validate the actual effectiveness of our work. So it is expected that the misdiagnosed rate of suspected cases, confirmed cases can be decreased after we apply these 2 systems. So, okay, that's basically our work. We have some experience to share with you. So first is, what do we benefit from openEHR? The first thing is using archetypes saved us quite a lot of time and lift our burden on understanding the data items, the meaning of them, while developing the CIG. Because by reusing archetypes, the meaning of the items are already elicited there. So it is much easier for us to understanding the items in the guideline and also their mapping relationship between the guideline to the real clinical data. The second part is most archetypes in the CKM can be reused directly. So we made some very simple statistic. We used totally 27 archetypes and 26 of them are directly acquired from CKM without any modification. And there's only one archetype has been adapted a little bit for the COVID-19 purpose. However, it's also acquired from CKM with some minor changes. And third is GDL and its editor. It's a great language, great tool that helped us to develop test guidelines very quickly and without any coding. So previously we used JUICE and other rule languages for creating guidelines. However, by doing that work is more or less like coding in Java, like in C or something like that. But with GDL, like experienced informatics can work with the rules directly without too much training because it's easy to understand. And also the validation tool makes it possible to validate the rules directly after we implemented the rules. So it can increase the process of rule development. However, on the other side of the coin, openEHR is not yet perfect at the moment of time. So the first thing, like we mentioned before, is the lack of open source or free GDL execution engine. We still did some quick and dirty solution, which is to translate GDL to the rule, to the JUICE rule, which we were familiar. However, this is time consuming and decrease the shareability and reusability of the rules, which is kind of unlucky here. So the second part is GDL2 editor currently still has some limitations. These two limitations we have confirmed with Dr. Rong Chen, who was the inventor of the GDL2. So the first thing is some data types are not yet supported in GDL2 editor, like the DV proportion, DV duration. They are not supported in the editor. However, they're supported in the GDL2 language itself. So we still need to open the rules by some text editors to bypass the editor. This kind of solvable, but not elegantly. The second thing that's really difficult for GDL, which is to support some collection data type, like the example below. For some cases, the trend needs to be analyzed. Let's say the white blood cell count is rising or decreasing, so it needs multiple data for one item. This kind of concept are not supported in GDL2. Although in the editor interface, you can drag the data item there. However, while executing, the concept is not really supported. This is what we have confirmed with Dr. Rong Chen, and he has some plan to work with it in the future. So to deal with the insufficiencies at this moment in time, we are proposing some work to develop open source tool by ourselves. So currently, based on the experience that we gained from COVID-19 CIG and clinical decision support system development, we are working on developing an openEHR EL, which means the expression language-based rule editor, because EL has better support to the collection concepts. And the execution engine that we're trying to make is also based on EL plus JUICE. We are planning to make it open source in the near future so that this kind of rules in openEHR can be really shared and used freely. So let me give you a quick wrap up. So there are three things that worth mentioning in our study. So the first is there is currently yet a lack of CDSS and knowledge base while fighting with COVID-19. This is the purpose of work. And what we did is we proposed an approach to use the openEHR archetypes and GDL and develop a CIG. So the approach is specified, clarified out of the other approaches. The others can use this guideline to guide their own CIG development approach based on openEHR. The third thing is we developed two CDS applications, and they are now under deployment in real clinical settings, and we hope it can be online soon. Okay, so this is basically my presentation. Thanks.
Okay. I see that Russ has a question about do you need to have a CDR in this project? Which CDR do you use in this project? So maybe Shan, you can explain a little bit about that.
Yeah, actually, we do not have to have a CDR in this project. However, we really have a CDR in this project because the CDR can really make the implementation easier. The CDR is developed by our own group, which name is Clever. So this CDR is openEHR based. So it integrates the EMR data to the CDR, and we use the openEHR based approach to query the data and acquire the data to the to our CDS applications. So the short answer is we do not have to use the CDR, but we did use the CDR. The CDR is Clever, developed by our own group.
So actually, that Clever CDR have been already implemented in the hospital 2 years before. So based on this CDR, we got not in this very serious phase of COVID-19. Not only we developed the clinical decision support tool, but also we support the support the hospital IT staff to quickly implement the data reporting tools, because in that time the Wuhan city has been closed. That means we cannot go to the hospital to support them because we are out of Wuhan. So the IT staff can use our Clever CDR to just develop their template for the data report. Yeah. Are you there?
Okay, so there's another question from Hiroshi Kai. Did this CDR successfully detected the case dismissed by doctors?
So let me give a quick answer. Unfortunately, our CDR and CDS is still on the deployment process, which means it's not actually being used yet. So we hope it can do so, but currently we do not have a concrete proof for that.
Okay, so we need a CDR. We need a GDL engine, so execution engine.
Actually, we did some translation from GDL to JUICE, so we can execute GDL in some way.
Okay.
Yeah, but we still need to integrate with the CDR and also the information system in the hospital. The hospital is in Wuhan, so it's kind of difficult for us to get there.
Okay. So next will be a question.
Okay.
So, okay.
Let me do some. Okay.
Thank you, Dr. Xiang.
Thank you.
谢谢.
Okay, I'll share my screen. right. Right. Everybody can see that, hopefully. All right. Can you hear me?
Okay, very nice.
Ah, thank you. Yeah, because we had some issue previously, I think, with the sound, so I was not sure I would put that in full screen. Okay, so I will talk to you about Airbase, which is an evolution of my previous work, and I will explain that. So just to make sure that actually I'm in the Asian side. So I'm living in Khon Kaen, Thailand, which is about 500 kilometers from Bangkok in the northeastern province, which is a very nice place, in fact, because when I hear all the turmoil regarding the situation since the beginning of the year, here I would say that apart from some difficulty to travel, everything was more or less life as usual, which is really nice, and we could actually work quite with a lot of serenity. Just about me briefly. So I'm from Switzerland, and I study there. I'm really an information system developer. That's what I've done all my professional life, and that's what I like to do. And I hopefully will be able to do that for quite a few years. I've been working for big companies, and I'm coming really from the big system background. So I've been lucky enough to work on large systems and so on, and large data centers, developing various information systems for finance, well, industries as well, and healthcare. Healthcare, I would say, since the past 15 years, really. I've created a company here in Thailand, and this company is supported by the Board of Investment since 2012, I think. I wrote Ethersis in 2011, and Ethersis really was a kind of personal challenge. It was also to respond to an actual project where we had to deal with telemedicine for ophthalmologists in the French Caribbean. Go figure, actually, from Thailand, it's quite a big hop in various locations, France, Caribbean, and so on. And in my research, I found that openEHR was potentially the best candidate in terms of information technology to adapt to a very complex domain, and also dealing with all the changes and so on that has been evoked before. So basically it was very convenient, and also it was, as an IT guy, it was a very convenient way to not isolate, but to have this this distanciation with the medical world, as the medical specialists are responsible for the models and so on. And me as an IT person, I'm responsible to host the model. So it's a very, very good, very neat approach, actually, and it relieves a lot of potential conflicts and misunderstanding. The thing is, actually, I'm working now for Airbase, excuse me, and I'm working on this migration. It's way more than a migration, really, from Ethersis to Airbase since 2019. Just on that side is actually it's some refreshing example of moving snow on cars in Switzerland to a new life in Thailand since the past 10 years now. Project background, Airbase. It's excuse me?
Question?
Yeah.
Slides is not moving, so share another screen.
Sorry?
Slides are not moving,
Slide, oh, excuse me. Can you see project background?
Perfect.
Thank you, Shinji. Actually, I'm not used at all of using Zoom. We are using Slack internally, and it's really a discovery. So thank you for the help. So background, actually, it's a major, I would say, it's an industrialization of EHR-6. EHR-6 has been quite many years one-man show exercise, and it was well, it was interesting, it was challenging, it was really exciting, but also it was very frustrating. And I would say I'm really glad to have been able, well, to integrate this new initiative, Airbase, because now we are really dealing with a completely different set of approach, also a lot of contribution, and it's really, really interesting. The team of Airbase consists right now of 10 persons. You can see that on GitHub. I will not try to switch screen, as that's what I wanted to do, but since there is an issue, I will not do that. And I have also to tell that there are 6 new developers, DevOps, and so on that will join the team very, very soon. So all that to say, there is a major evolution coming, and I might be able to tell more about that later. What is really important compared to what we were doing is the set of methodology and project management which is associated with this effort. Of course, with 10 persons, it's a completely different way of working, which for me was also interesting in terms of adapting to this new mindset. But I would say it's very, very rewarding. And one great benefit also, we have completely moved the architecture, I would say, to modern tools. While I would say Spring Boot is quite nice. I'm not a big advocate of framework in general. This one is really nice because for newcomers, they can really get on speed very quickly. Switch to the next slide. First, the key mission statement for Airbase is to be open source. I would say, and I start to think that very seriously, that in the future, open source, most software is going to be open source. And I think with a disaster, I would say a situation like COVID-19, it's very interesting actually, especially when you look at what is happening in the US and so on. The difficulties people have to share information and so on is really, really depressing. And the thing is actually, when it comes to open source, open standard, interoperability and so on, I think it's getting really critical now. And it's not only in healthcare in general, but in healthcare, it's, I don't think you can really consider going without now. Airbase is entirely based on the openEHR specification. And one of the big points of what we are doing right now is to be in conformance with the openEHR specification. Fortunately, in the team, we have people really who are very careful and disciplined about surveying that we stick on that specification. Because as a developer, I'm very happy actually sometimes to drift and to implement my own things, but basically that is very important. We want to be an alternative to proprietary platforms, especially when it comes to all sorts of development in-house. What we aim to achieve is actually providing the backbone, but also something which will be quite easy to use in real life. You will see quick videos about how that is coming together in real life, actually. One very important stuff topic is the platform we deliver is not only, it's not a proof of concept. We are really working toward providing an open source, so I mean available to anyone, an open source enterprise grade platform, and we are really working on that. So we have the tools, we have the methodology, we have the technology allowing to do that. Project governance, I should have put IMED really, or I should have put the way around actually. The first part, the first governance is open source. What we do is readily available, and I'm sorry, I'm very glad actually this came out as the paradigm, in the sense that there are some commercial interest, of course, in a development like this one, but we want to make the platform a commodity available to everyone. After people develop a specific application, whether open source or commercial, well, that's their objective and responsibility. But what we want is to provide an open source platform that is actually available to anyone for any reason. Fortunately, when you deal with open source, especially for a system like this, it is generally driven by political decision, and I think that's a very interesting point. IMED in Germany is part of it's a consortium actually. It is sponsored by the Ministry of Education and Research and Medical Informatics for the whole country in Germany. I think one key point, and it's discussed a lot, is public money should fund public open source systems, software. And I think that is really interesting when you move into that direction, because especially now, there's a lot of money being injected in different countries. And I think it's really critical that all this money is actually can be reused in an open way. I'm working personally both for the Hanover Medical School, which is a very strong driver in this project, as well as for the Vita group, Vita Systems, which is a part of the Vita group, which is a commercial company, in fact. But Vita, interestingly, thinks that the platform, the backbone, should be open source, and they develop commercial application on the top of it. I will talk more about methodology and the way we work instead of digging deeply into technological stuff. We have a nice way to work regarding the evolution of the development. Everything is based on the issues and stories, so it's an agile development, if you like. By Scrum, basically, and we follow this approach where you have scenarios, coding phase, and that everybody know from the book at least. But that's the way we work. And a very important part here is, especially that is really unit testing, but you will see that by extension we use a complete test framework, continuous integration, and so on. But the behavior-driven development allows actually to have short micro-release cycle, if you like. So every 2 weeks we have sprint, and I will go to the next slide. So every 2 weeks we have deliverables. We check that and we go to the next phase. But of course we have a roadmap and so on, and but all these various phases of the sprints, they are checked every 2 weeks. This is very, very nice way, because first, the team is very dispersed. We have people in Uruguay, Spain, Germany, Thailand. And if you don't have actually a way to put that together methodology-wise, it's not working. That's the reality. So we have a tool chain to support all that. Since everybody was working from different locations before actually we were either locked down or dispersed in remote location. So the general project planning and the discussion is based on Confluence. That's like the Chinese team. We use extensively GitHub for our stories and issue trackers and so on. And by the way, if you go on GitHub for Airbase, you will see that mostly everything is public, which is quite cool. We use standard development tool. Is Java based. We use a very interesting Java framework for interacting with the database. We have based the development, and that's also a major change from Ethasys. We have based the development of the openEHR reference model on Archie, which has been developed by a company called NetApp in the Netherlands. And this has been really a breakthrough because it provides a lot of components that we don't have to develop, especially when it comes to serialization, validation, and that is a very, very nice development framework. A lot of things actually are developed in SQL as well. And I will come to that later, but basically it's a very important part because in terms of system architecture, software architecture, the middleware is sometimes a very important bottleneck. And also SQL is very mature. It has a lot of tools in the ecosystem, especially when it comes to optimization, monitoring, and so on. And I think now we are really seeing that there are huge benefits of going that way. Very important part is test automation, continuous integration. This is a major change from the previous, from Ethasys. Members of the team have developed a complete test framework using robots, and that is super important because with a project of this complexity now, it's very, very easy to introduce regression when you do changes. That is actually very neatly detected, and it's improved. It's constantly improved, and we are making really big progress. For me as a developer, it is very good also because I don't have this constant worried in the back of my mind if I'm changing something, whether it's going to break something in the other part of the system. I can really use the test automation as a tool to verify what I'm doing. We are doing now load testing. For those actually who already follow what is going on GitHub, I'm doing a specific change to AQL to improve the performance of it. So that's going to be verified using JMeter very soon. We do code quality checking in an automated way using Sonar, but also we do peer review of the code. And that is also a very important part of the development process. We have on one side this peer review that is used to verify or to comment changes that has been done to the code base, but also to be able to spread knowledge on the code. So one of the danger, and that was the case with Ethasys, is when you have one person who is knowledgeable about it, well, if that person has a problem, then basically the project is dead. But here with that, we have actually a way to communicate about the code between different members. We package and release using different scenarios. There's a lot of things already in Maven Central, so you can use part of the libraries, generated libraries, as dependency into your own code. Also, for each release, we automate the building of Docker containers. So that's for easy deployment. It's not saying that it's difficult to deploy Airbase. It's not, in fact. But basically, when it comes to do a quick evaluation, or also you can imagine also different scenario, you can use Docker containers. Communicate using Slack, so hence my lack of knowledge with Zoom. And IMED, just for going a step above in terms of abstraction, IMED has also a CKN. Let's go into the platform architecture. On an external standpoint, the communication point, the gateway, is the REST API. The REST API as specified into the openEHR specification. So we follow strictly that specification. That is very important because semantic interoperability, sure, we need to have that, but we need also to have a consistent way to communicate between different openEHR platforms. So we test using Maron, for example, or Dips, as well as our own system. And that is really interesting because especially when it comes to AQL, for example, we can verify that what we are doing is actually consistent across different platforms. The benefit of using Spring Boot is the introduction of authentication and authorization. Actually, it's an OAuth compatible platform now. So you have really capability to implement single sign-on web token across different components also. We are developing right now an administrative console based on the platform, which will allow you to deal with security profiles, do some cleanup and so on. The core component of Airbase is the database persistence. There is a lot of things happening at this level, which is used by the different components. So whether dealing with EHRs, so that's a high level. We have the contribution now completely working, template handling, folder in directory service is implemented, of course, composition and querying, which is a big part. Going back to that querying AQL, I think it's one of the most important features of that platform, and we are just scratching the surface in terms of its capability. It's a very powerful, in fact, very powerful query system, which will allow to implement further scenario like parallel querying, distributed querying, and this kind of things. That's what we are looking for. Another important split of the platform at platform level is we have introduced the client library, and you will see that on GitHub, the Airbase SDK. Airbase SDK is dealing with low-level stuff, but not only. So like template handler validation and serialization of RM objects, dealing with internal technology, And you have this component here, generator. The generator is a very important change. It allows to generate from a template the Java classes you will need to directly interact with composition in particular. So instead of, and I know there are a lot of complaints when it comes to dealing with composition object, especially when it comes to create or update and so on, is the payload you have to pass at the REST level is rather complicated. With the generator, actually, you only deal with Java class. And it's quite simple. I think I gave an example later. So, but basically, once you have your set of Java classes created from a template, you just deal with standard Java object, and it comes really, really in a very natural way. It is also used by an important component that I will discuss later, is the fire bridge. Underneath, we have the representation of the reference model using NetApp RT. Contextually, Airbase can be seen with three components now, very simply put. When I say server, it can be into the same machine, obviously. It's, we are thinking about, say, a Unix environment, Linux environment. So basically, the server is running is a running service inside your system, whatever it is actually. So the Airbase server itself is dealing with a database server, it's PostgreSQL. We have some possible future developments regarding integrating other database systems, especially it comes interesting where we want to insert that platform into existing environment where they have contracts, for example, with Oracle. So that's the idea. Fortunately, what we are using now in PostgreSQL is compatible with most modern database servers. Firebridge here is interacting through the SDK to the Airbase server, an existing running instance, and it captures fire profiles basically, and convert that into openEHR objects. The identity server is an important service now because we are also compatible, so you can integrate Airbase into an existing single sign-on environment. Another capability which is new compared to Ethersys is the capability to query using terminology commands in the format of a Fire terminologies server. So that's an important part. And for example, you can connect your queries to onto a server, for example, from Xyro in Australia. Everything connecting to Airbase is based on REST, whether it's for client application or clinical modeling when you inject new templates, for example, in the platform. So in terms of bullet points, Airbase is now is a REST API. It's a REST server. It's a secure. It's not only OAuth2, by the way. A basic authentication is also working. It performs the openEHR transaction that you would expect, and also it has quite a good framework regarding object validation at different levels. Object querying is fully based on AQL. You have the maintenance of local knowledge models, especially templates. It's a data-centric architecture. So that part is rather important because as a developer, I know the difficulty actually to reinvent the wheel and to make things overly complex. Sometimes it's a bit of excitement, it's a bit of fun, but really when it goes into a system that you deploy in real environment, well, it can be really a major problem, a major challenge. So here what we do, we minimize code and maximize the data. And maximizing the data is, it's not only pure data into the database, but it's also a lot of operation within the database, rules, conversion, and so on, that we don't need to do at the middleware level now. That is also a very big change compared to what we were doing in Ethasys. And what we do, we comply with openEHR latest specification. Quite a few members of the team are either directly involved into the standard editorial committee or are part of some expertise group and so on. But anyway, we monitor that very closely and we stick to the specification. The SDK is responsible to manage the knowledge representation that are coming from the clinical modelization. So it means the templates basically, and everything is maintained within the SDK now. Which is nice in a way, because if you want to implement a completely different system, you have actually at hand all the manipulation, all this cumbersome manipulation of knowledge representation and RM object validation and so on at this level now, without the database, without the service framework, authentication, Spring Boot and so on. One thing which is very recent and we are exploring now and we are using is the conversion of templates into plain old Java object classes to make client implementation way easier. We give you a very short example on how that comes together. So that is actually a very neat way to have a quick access to the platform. Provides Airbase with APIs using Java method to deal with all objects we are considering, especially when it comes to serialization, EHRs. The querying, there is an SQL builder within the SDK as well. So you can actually create SQL queries directly within the SDK using Java classes. So that is really, for those who are familiar with Juke, the Java framework we are using to interact with SQL. We don't write plain SQL in our code. So basically you can do the same thing with SQL. It also minimizes the errors you can do when creating SQL queries. It also deals with the directory RM structure from openEHR. Yeah, last but not least, it generates the REST API payload you would use to interact with the REST API. You can get that from the SDK. So here I give a very quick Java example, a bit shortened for the screen size. But basically, when you have a template that modelize an Airbase blood pressure simple, that's for Germany, version 0 composition. So that's what you do, you create a new instance. Then you add the value directly using Java methods, so set systolic, magnitude units, and so on and so on. Then you are using your endpoint client, you assuming you have an already existing EHR ID from the previous transaction. then you merge it into this EHR ID, and then and then you retrieve its version ID. Simple, huh? I think it's quite stunning compared to what we were the approach we were doing before. This is a very, very important step in the right direction, in my opinion, to simplify the development of client application. By the way, this is Java, but currently we are working on integrating that into popular JavaScript framework like Angular and so on. Firebridge. There's a bit of excitement around this one too. So it's fully based on the Airbase SDK. And what it does, it's quite simple in a way. It's first of all, it's be able to interpret file profiles and convert them into their corresponding openEHR RM objects. So it's based on templates, and one important part actually to consider when it comes to Fire has a different, quite a different philosophy about a large number of things, I would say. But basically, the logic into the Firebridge is to either map directly Fire resources to its corresponding composition, but can be also distributed among a number of compositions, as you probably know. So basically, that is the role of it. And when the transaction is done within the Firebridge, it stores that into the CDR. So that is actually one thing we are quite using for the COVID-19 platform, that I will show you very quickly into a video later. So that is actually evolving. We have a group of people now working on the actual mapping between file profile and resources to actual openEHR compositions. Another part is the link. So that's what I evoked before. I will give you here an example on how we bind Fire terminology service within AQL, and it's all completely based on the AQL matches operator. So here, for example, if you want to deal with an expansion within the terminology, you just express that with this invoke statement as an expansion, and then you retrieve the corresponding values corresponding to this command. That's here using OntoServer from Australia. So this is a very, very interesting way to do easily this terminology integration. Well, you can see that actually discussed fully on our wiki space in openEHR. When it comes to operating Airbase, so it's very simple. In fact, the deployment either as a standard Java application with the database, of course, which would be probably my preferred way because I'm very old-fashioned and old school when it comes to deployment, and I like to have full control on things. Or Docker, we have a Docker image for Airbase as well as for Postgres. One side note regarding deployment, Airbase can be deployed on popular cloud provider, which is was not the case actually with FRC. So now we can deploy on AWS, Azure, DigitalOcean without any problem. It's actually now fully supported. And as I said before, we are working on developing an admin console for monitoring and doing the necessary task when Airbase is deployed. we'll not spend much time talking about the COVID-19 platform because we talk a lot, but anyway, all that is actually gaining a lot of momentum since we are quite involved into the national COVID-19 platform for Germany, which is a distributed platform for German university hospitals. And Airbase actually is planned to be used very neatly to interface a number of applications, whether it's self-assessment or it's hospital-based. And that is really interesting because with all this effort regarding COVID-19 knowledge models and so on, we have actually a very interesting way to integrate all these components together. I will show you this video, which is in German, and it's very short, so don't worry. And it's actually the platform we have been demonstrating when it comes to integrating an application really on the top of Airbase. So I'll show you that. I hope I can pause it. So that's actually the front page of the core platform, where you have the patients that are actually currently into the EHRs. That's also the number of records you have corresponding to these patients. And you have the distribution per universities. That's also on a technical side, that's the different templates we have been using with the number of records that have been attached to these different templates. So well, I hope it's working. So yeah, it's skip. We have different statistics associated to that. And we can have a view on the different results corresponding to the different templates. So based on patients. So for example, here, so here we have for a given existing patient. We can search on the different criteria using a very simple query interface. And here, for example, we are interested to have the lab results corresponding to this value. Gives actually the list of patients. You can see actually, I will just pause here. When it comes, this system is not connected to a master patient index. So basically, there is no administrative information regarding the patient. But here you can get the detail here. So here you have the details corresponding to that patient with some charts. Date of diagnosis and so on. I hope it will go to the next page. Yeah. Lab results. You can explore the charts. Okay. Yeah, and you get the SOFA score actually for that patient, corresponding to what has been entered into the corresponding template. Okay, so that's actually an example of Airbase in use in the context of COVID-19. I will show you the next slide is a bit more technical, is about next slide. Okay. Next slide is a bit more technical and is how we populate the data for a patient using FireBridge. So here now we have no information relevant. So basically here we are doing. Oh, sorry. I need to go back. So I see. Again. So I will try not to interrupt it. So here we have a resource that we want to convert for a given patient. So we will run that. We are using Postman, which is really popular, and we run the FireBridge through Postman, and we generate the different data corresponding to that patient into Airbase, and we can directly visualize this information. FireBridge needs to have a bit more packaging, I would say, to make it more user-friendly in terms of usage. But most of the low-layer parts are really usable right now. And that's all for me. Are you here? Oh.
We are Christian.
Oh, I was actually very confused. It was completely silent. Yeah.
Shinji must still be on mute.
Okay.
Shinji.
Hi.
I have finished.
Okay. So do you have any questions?
I think
No question?
I think the best way regarding this is really to if you have any question, unless it's very general, contact me or any member of Airbase to get more details on because it can be quite long really to go into further details when it comes to technical data like this.
Okay. So for example, so I many questions is I got many questions from open beginner about FireBridge. Is there any FireBridge, or is it easy to implement it, easy to transform? But so it takes a long time to answer. So
yeah, I can answer that. The thing is, it's an ongoing exercise. There are a number of profiles that are being introduced. You should actually go on our GitHub section regarding FireBridge, and you will get more information regarding what is actually available now in terms of resource. But we have a group really working on that now about the mapping between Fire resources and openEHR objects.
Thank you, Christian. Do you have any question about? Do you all have any question about the presentation in all the presentation of today, or some discussion? Why should we use both openEHR and Fire? I think Fire is message oriented, and openEHR is record oriented. So we use message for Fire and openEHR for repository and querying data repository.
Oh.
Is it right for, is it right?
Yeah, I can add actually, there's constantly this question. The data model is completely different. First of all, FHIR is not, it's an evolution of HL7. So HL7 is mostly, is an evolution of EDIFACT X12 from the CCITT, how to exchange business data between systems. And HL7 contains first business information pertaining to hospital operation, billing, and these kind of things. It's a business messaging system. It comes also with some, I know I will have a lot of enemies saying that, but basically it comes with some clinical data as well. But the clinical model of this data is completely flat, except immunization or medication, if I can say, because immunization and medication has a billing content. So it's really cool to make it a bit more sophisticated. But here with openEHR, we do something completely different, really. The clinical data is completely structured, and it's not a billing information system to start with. So when it comes to querying and implement complex query and so on, we have a very interesting model that we have a very good query language as well, which FHIR doesn't have. And also, we have the emulation of the clinical process in time as well. So we can do all sorts of very important statistics analysis on that. And that's what we have been using with the people of COVID-19 in Germany, because the query they are doing on Airbase are very sophisticated. And that's a very interesting point.
Can I add something in there, Christian, as well? From the clinical modelling point of view, certainly what I've seen and talking to people, the HIMED work and what you're doing with Airbase is really one of the most advanced examples showing how openEHR can work with FHIR and with SNOMED or other terminologies. And it's a really good working example, and we should all be watching to see how this evolves. Because I think it is a shining light in how to get the right standard being used in the right place, rather than following kind of, I guess, religious rules really around whether you're a HL7 person or an openEHR person. It's actually saying let's use the right tool for the job. So I'm looking forward to seeing how that evolves, even though I only understand about half of your presentation, but I appreciate it and the philosophy behind it very much all the same. My experience from a modelling point of view in Australia is interesting because openEHR is really not being used very much at all, and yet I am currently engaged in a project where we're building FHIR implementation guides for particular use cases, and it's a Commonwealth-based, Commonwealth-funded project to develop a data dictionary in primary care. And I'm engaged as an information modeler to bring the openEHR content into this environment. And what I've found is when I present the archetypes to the clinicians who are saying yes or no as to what goes into the content, they're almost universally accepting my recommendations with hardly any discussion, because they just say this is the best models that they've seen. And yet there is no openEHR output from this. In fact, it's very consciously a FHIR output. And so this is, we've got openEHR fueling this project and underpinning this project that's actually going to have FHIR outputs. So it's going to be interesting to see how that evolves as well. But the discussion I had with some of the FHIR developers the other day was interesting in that we are going from a very simple model around tobacco smoking to say we want to have more than just a status of are they currently smoking or an ex-smoker. We actually want to have some content around details about their smoking. And when the FHIR people started to look at that, they started scratching their head because they're going, I don't know how to implement this. It is much more complex than what we've done. And all they could point me to was a vital signs profile that had been done previously. So they're suggesting that for every data element in our tobacco smoking profile, which the clinicians want, they would have to create individual observation profiles, which would, and then bundle them together. And I'm just going, scratching my head in response and going, this is not sustainable. So the clinical content side of openEHR is far in excess of anything that's really been done in real life in FHIR at the moment. And I think that's a challenge that we're all going to have to explore a little bit.
Okay, thank you, Heather. So maybe the last question is from Bunchai. Is openEHR implemented across German? Not all German, but
it's a good question. Actually, just stay tuned for the next week or two, and you will have a lot of more information regarding things that I cannot talk about now, right now. I'm not entitled to talk about that, but just stay tuned 1 or 2 weeks. It's coming.
okay. Okay, thank you. Is the Thomas? Thomas.
Oh, can you hear me?
Yes.
Okay, thank you, Chinji. Heather and Christian is very eye-opening, and also the team from China, and I learned a lot from this. So my last question is to maybe Christian. I heard that for the COVID-19.
Thomas.
Some regionals in German use the the software called SOMAS, the surveillance system. My question is that how they link any linkage between the openEHR with the HiMed group and the SOMA developers. It means what I mean is that do they implement the openEHR into the to the SOMA applications?
I heard it before, but not the same team or HiMed team, but they're working in same university, but another team. I heard it. Okay.
Yeah, I can come to you with more details about the integration of the different applications because in HiMed there are a lot of different applications, as you probably know, and but basically for the COVID-19 platform, the aim is to integrate that, to distribute that into the German university hospitals. So basically, there are a lot of different interfacing. I would say the interfacing, especially when it comes to this type of application, is probably not the most difficult, I would say.
So SOMA is one of the application tools that recommended by WHO for the COVID-19. It has been implemented widely in Africa, but it originates from the German government. And I heard that some regional in the German government also implementing this kind of the system for the at the time of the COVID-19 pandemics. Just curious about this kind of the two works have been do they are working or have been working together?
Yeah, I can come back to you with more details regarding this integration, if any.
Okay, thank you.
So thank you for joining. Very good. I think so. Just we had some trouble, but totally very good discussion and very good discussion and presentation. Thank you for Chinese team and Christian and Heather today. This openEHR summit is also a successful one, and please stay wise and stay healthy in your country and work harder to fight against COVID-19. Okay, so please enable your video and share one photo.
Thanks for organizing, Shinji.
Yeah, grouping.
Yeah. I was wondering how you want to do the group photo.
Group photo. I'm trying.
Yes.
Okay, so please.
I think you should unshare, and then we will have the full screen, so we can have all the pictures.
Okay.
together.
Yes. See you next Asia Summit, maybe in Sydney.
Oh,
Yes.
Okay.
The next
I'm ready for.
next summit maybe face to face, I think.
Yeah, face to face.
I hope so.
Face to face with alcohol or something.
Yes.
Okay.
Okay.
Bye.
bye.
Goodbye.
Bye.
Bye. Goodbye.